people are obviously running late this morning, but why don't we go ahead so that we can hear what our friends have to say about rural healthcare in the crisis in the quiet corner. Um, I know all of you, and you know all of them, so nobody needs an introduction. And I think our favorite former state rep Pat Wilson Pheanious is going to kick things off.
Well, yes, indeed, I am. Good morning, everybody, and so glad to be here to talk about this important topic. One of the things that Susan Johnson and Arvind Shaw and I did in preparing for this workshop was to look at some clips that have been recently prepared in testimony by the NAACP for a potential certificate of need hearing for the Wyndham Hospital. And we'd like to play a couple of those clips because I think what they do is capture some of the problems that people are experiencing in our healthcare system that we're going to flesh out a little bit more as we go forward. So we have Francelis Gonzalez and Michelle Jones, who again testified in a public hearing. And we'd like to play excerpts of their clips. We've shortened their clips, but we thank them for their community participation and for sharing their stories with us. So Chris, if you would.
So I'm a community outreach worker for Wyndham Public Schools. And
hold on. I hit the wrong button. I do better when there's a big crowd.
That's all right.
Let's see here now.
It's a nice thing about being just a few of us.
Why is it not showing up? I swear to God, it worked just a few moments ago.
It did. We practiced.
We heard it.
There it is.
Okay.
I think. No.
Okay.
All right, this is crazy.
Well, you're amongst friends. We're amongst friends, so.
Thank you. All right, I have a different way to do it.
Okay.
It'll take me just a second.
Not a problem.
This is all being recorded, right?
Yes.
Julia, yeah, it is recorded. Not to worry, but we'll edit this.
This is being recorded.
But that means Steve Jones and I could use this with our respective town councils.
Yeah.
Parts of
So
this
we'll start the recording right here.
Okay.
And give me just a second to cue it up. Go to share screen. Oh, now it's showing up.
Here we go.
So I'm a community outreach worker for Wyndham Public Schools. And I can say that I work with a lot of Hispanic families. Closing down the maternity unit would be very detrimental to our community, especially our Hispanic community. I have families that tell me on a daily basis that they worry about transportation and how they're going to get there, the financial burden that's going to cost there. If they have a premature child, you have to stay in the hospital, and sometimes they have to stay in hotels depending how long that child has to stay in the hospital. And there's no way, like, who will be paying for these hotels, who's going to be paying for their meals. They worry about things like that. I have a daughter myself. My daughter was born in 2016, so this was around the time that Mansfield was transitioning out of Wyndham Hospital. I had the option to deliver at Manchester or Wyndham Hospital. I chose that I wanted to deliver at Wyndham Hospital. When I was 6 months pregnant, I was getting really bad contractions, and I went to Wyndham Hospital. When I went to Wyndham Hospital, I was told that I needed to go. I was given a shot, and I was told that I needed to go to Manchester. Luckily enough, I had my parents that were right outside, and I could get in the car and go to Manchester. But I think about the families that I work with on a daily basis. Not only there's a language barrier, but also there's a barrier right there that not a lot of families can get in the car and go to Manchester, get in the car and go to Norwich, get in the car and go to Hartford. As State Representative Susan Johnson said, what happens if there's an accident? This is going to increase a lot of at-risk pregnancies. A lot of parents that are not, like, they're not going to have that resources of just going to Wyndham Hospital, going right there, knowing that there's safety going there. So I worry a lot about that with my families, and they share that worry with me. And I'm here today, I'm speaking on their behalf because there's a huge population, A1 that make up. So thank you.
Okay, hold on. And let's get to the second one. I'm sorry this is so clumsy.
I'd like to speak about my daughter. When she became pregnant and Wyndham Hospital, knowing of her psychiatric issues fully for the last 4 years, they had given her a doctor at Wyndham Hospital in the beginning when she was only two months early pregnant. Well, she missed one or two appointments. We to Hartford Hospital for maternity care, which created financial hardship for her on top of her mental disparities because now she's pregnant. She had to travel 28 miles in an Uber to go see about herself because Wyndham Hospital would not service her. Which for all the prenatal care and all the Ubering, she went into labor premature, and it's a good thing I was there. When I contacted the ambulance, they got there and they said, oh, yes, she's ready to go. They proceeded to take her 16 miles while she was in premature labor to Norwich Hospital instead of taking her up here to Wyndham Hospital. And she had the baby on the side of the road. We couldn't even make it to the hospital when the hospital is only, Wyndham is 4 blocks from her house. And they know of all her situations. And so as we did that, once we got to the hospital there, the child wound up staying in the hospital for 5 more days. They had to transport him from there to Hartford Hospital because he had a few issues, being born on the side of the road prematurely. And like I said, we live right there. But then traveling 28 miles and knowing she was a psychiatric patient as well, they put her in a diverse situation. I wasn't there with her. She was trying to take her medicine, get her own self together, and have her baby and do good. But they would not allow her to come to that particular hospital. And running back and forth to Hartford in the situation and in the mind frame she was in, that only kind of messed her up a little bit more and traumatized her and her little baby a little bit. Then when she went into labor, we got the people, I will be honest, they got there real quick because like I said, she lives right there 4 blocks from the hospital. Why would you try to take her down the road seeing that she's crowned? And it's not that Wyndham Hospital does not know about her psychiatric because they've been treating her, like I said, for the last 4 or 5 years. So that if you're going to treat everybody fair, why would you do that? Put that type of person in that type of situation. And you caused a lot of stress and trauma. Plus, you caused financial hardship, which created more trauma for her. And then they refused to service her at that hospital at any time. And it wasn't because they didn't have a doctor. They said it was because I went to Connecticut. I'm in New Orleans at this moment. And this is where I've tried to reside. And I've been coming back and forth for maybe 6 months since we found out she was pregnant and stuff started happening. But since they had a doctor there, even though she missed an appointment, they said, we're just not going to deal with it. That was pretty much their attitude at that hospital. And I am very upset about that. Because now I have a little 2-3-month-old grandchild that has gastric problems because instead of them taking him where he could have been treated immediately, they had to try to take him down the road and the paramedics had to deliver him. So I don't see how that's valuing anyone. And I'm going to go a step further and say, I know it's about women and I know it's about women of color, but just another life itself that you put into danger, not only her, but the child. So how do they justify that? So I don't know what to think. I don't know what we can do about it. I would pray that that they would try to see that there are many women in that community that need the help. And in this case, you had a special person. She wasn't just a normal person that could go on her own and do things. You knew she was having mental issues because she couldn't take them. They the one told her she couldn't take the meds because she was pregnant. Then 3 or 4 months on, I found out that she could. But by that time, they had her in a mania for 4 months with no kind of help, none. traveling different places trying to seek the help she needed. So how is that helping the community?
Well, I'd like to thank those ladies for sharing their stories because it really illustrates many of the problems that exist in our system and why I think that we're vulnerable in many ways. There were observations of transportation problems, problems related to income insecurity, mental health issues, folks with multiple problems. Poor people often come in with a whole package of problems, and ultimately a child placed at risk. When I think about healthcare in our area, I see the vulnerabilities in terms of the fact that we're a rural community, in other words, in terms of place, in terms of the population we serve, in terms of the individual persons that we serve, and the power or lack of power that we have. In terms of place, we share the vulnerabilities of rural communities all over the country and in many ways, but certainly in our area. There are larger distances between people in rural areas. There is a lack of public transportation around here. Our providers are paid less. There is a patchwork of services in our area. These are all place-related kind of vulnerabilities. We live in one of the health professional shortage areas, which means we have fewer service providers caring for us. And yet we have in our area an increased incidence of chronic conditions like hypertension, diabetes, asthma, cancer, which everyone has equally, but more people die from it in our area. Our mortality rates are higher. We have child and adult obesity in larger numbers, higher lead exposure, tick-borne diseases that others don't share, behavioral health deficiencies in our system, and child abuse and suicide. These are all things that impact our area. These are all place-related things that we share with many rural populations. The population itself that we're dealing with, we have less economic wealth in this area than we have in many other areas. We have a larger Medicaid population. That means largely we have increased health disparities, because there's an impact of the social determinants of health when you're dealing with people of lesser income. So you're looking at income, education, housing, insurance coverage. All these things are, people are vulnerable when they come from a poorer area and a rural area. Then you look at our vulnerabilities when you're dealing with the persons. Women in general, I mean, have special healthcare needs that we have to be concerned about. But there's also our population, when you're talking about women in particular, we have less stable employment. All poor people are generally less likely to have sought preventative care. So when we present at a hospital, our conditions are often more complex because of a delay in care. We have language barriers, and folks with lower income and minority populations, for very good reasons, have developed a mistrust in some instances of the medical community. And our relationships aren't all that they could be. I know the medical community is working on cultural sensitivity and reaching out to people in different ways, but there are still these barriers for many people in our communities. And when you're looking at, again, the person, when you're looking at women and women's healthcare, there are more smokers during pregnancy in our area. That means more low birth weight babies. Teenage pregnancy continues to be an issue. So these are issues, like I said, of place and of person, but then there's the power differential that we suffer from. I think the quiet corner has gotten its sort of name. Unfortunately, people don't listen to us. We don't make enough noise, I think. Somehow they think that being from the quiet corner, it seems to mean we don't count as much because we are underfunded in ways that others aren't. When you look, and I think Susan will go a little bit more into this, but we have been traditionally underfunded. This is not a new thing for us here. When they do community assessments, they don't do them as thoroughly in a rural area, I think, as they do in city areas. For example, we had a community assessment done recently, and it wasn't even done in Spanish. It was done, it was a completely English assessment, and yet we have a large Spanish-speaking population, but that's an example of a lack of power. There's also evidence from my perspective of an increasing corporate culture that's come into our healthcare. 4 or 5 years ago, and Susan may talk, and Arvind too will probably talk more about this, our smaller community hospitals begin to be absorbed in larger health settings or health care conglomerates, if you want to call them. And I think our healthcare began to suffer when it left the community. And I think that a kind of a corporate approach that looks at saving, maybe not saving money, but trying to create efficiencies within an entire system that are not necessarily taking account of the individual needs of our specific community. I think that all of these things combine to make us vulnerable. And I know these things have a history because I'm newer on the scene than our other two panelists in many ways. I mean, I've lived here all my life, but in terms of being engaged in these issues, I look to my friends Susan and Arvind because they have developed years of intense effort in struggling with some of these issues I've outlined. Susan, you have a lot of history in particular in this, both in your work with legal services and now for many years as a legislator, a fellow legislator for a quick session. But talk to us about some of that history.
Well, thank you so much, Pat, for this. This has been an excellent review, and also bringing in the two people that we have who were refused by Wyndham Hospital, which I just have to say, hearing this again, because we were both on the call with the NAACP about a month or so ago. And it just strikes me as the first thing right off the bat is that Wyndham Hospital, through Harvard Health's new policies, had actually violated the EMTALA laws that were put into effect back in 1986. And the EMTALA stands for Emergency Medical Treatment and Active Labor Act. And by taking somebody and being in a circumstance where they are in active labor and they are refused care in the emergency room and sent out without having completed or stabilized the person is a violation of EMTALA. So right away, we're seeing that violation occur. And then also having, and you've got an emergency room there that hasn't been dismantled yet. But let's go back to what actually happened here. Back about 5 or 6 years ago, when the Harvard Health came in and decided to get rid of the critical care unit. And the critical care unit became a progressive care unit instead. All the doctors in the area, they protested this in one of their meetings, but the Harvard Healthcare and the administration failed to listen to them. And because of that, what happened is the OBGYN practices decided to practice elsewhere. They're either in the Norwich area, or if they're located in Mansfield, they're going to Manchester. And so that leaves us out. That leaves us without OBGYN services in the hospital. However, we do have our generations, and Arvind will talk about this a little more. And they're providing pregnancy care and treatment to people before they deliver. So, but now generations and the work that they do for women has actually been cut out of being able to provide the services, with the full range of services right here in the community. But, and going back to what you said also, Pat, having a situation where we are not a hospital that is located in an area with transportation systems that almost every single other hospital in the state has. Most everybody has a highway that they're able to access. We don't have that. We have rural transportation systems here, and if there is an accident on the way to one of these other places, then what will happen is the person will deliver on the road. And that is not what the Harvard Health people claim, creating more safety issues. No, it actually creates bigger risk because they're refusing people in violation of EMTALA, to go elsewhere when they're in the midst of having a baby when they're in the active.
Well, the baby born on the side of the road is a perfect example of that one.
Exactly, exactly. Or someone who's in labor and told to go elsewhere. That person, no one knows when the person will actually deliver when they say they're in active labor, and they are. So this is something that that we have a real problem with. So why did Harvard Health do this? Well, if you take a look at what we have the only Medicare designated hospital in the state of Connecticut, which we're fortunate to have. That was done by Congressman Joe Courtney. He created the only Medicare hospital because why? Well, because the patient mix here is such that it's mostly Medicare and Medicaid payments. So the reimbursement rates have to be higher. And so when you have a patient mix that does not include private insurance, you have a reimbursement rate that's way too low. And so the private insurance companies generally pay about 120% of the actual cost. And these are these negotiations that occur every so often that you hear about, well, we're not going to take any more. And I think we passed a law a couple of years ago to say, oh, you have to take people, and this is your negotiation, and you're not going to draw the public into it. So we solved that problem in the Insurance and Real Estate Committee. But we still have the issue of so many people who are in need of health care not having private health insurance, since a lot of the private business and industry left this area. And so now we don't have that many people who are able to participate in private insurance. And so the patient mix, again, is not what Harvard Health would like for their bottom line. And so that's why they closed the critical care unit, which caused the doctors not to be here. And then as we move forward, now they're closing the maternity ward, and they're doing it under the guise of saying that, we're going to have you go elsewhere. But they're not following the EMTALA law, which is a federal law for their certification for Medicare and Medicaid. They're not following the law that they should be following with respect to providing the access that they need to do through the new program that we developed back after they got rid of the critical care unit and created a progressive care unit, and the doctors left. We went to work in the legislature to create the Office of Healthcare Strategy. And the Office of Healthcare Strategy is supposed to be equalizing access to healthcare for people all throughout the state of Connecticut. So by Harvard Health going through this process of reducing access to care and actually violating EMTALA without having anyone having complained yet, what we need to do is we need to go through the hearing process. Harvard Health itself raised this issue because they realized that they were in violation of the law by changing the healthcare services without going through the process that they needed to go through the Office of Healthcare Strategy. That again was created because when they actually reduced access to the critical care unit, the state said that they didn't really have any way to oversee that reduction. And that's when we created a task force with Nancy Wyman, healthcare providers all throughout the state. We met for almost 2 years on those issues and created the Office of Healthcare Strategy so that they would have resources, they would have direction in statute to actually review these types of circumstances where cutbacks are made, particularly since it's not just Harvard Health that's done these mergers and taken on smaller hospitals. It's Yale New Haven, and it's in the Danbury area as well with the Milford Hospital providers. So we have this going on all throughout the state, and access, of course, I'm familiar with the access here, the problems here, but there are access issues all throughout the state for low-income people. Right. And then going back to what we're going to hear from Arvind about is the fact that historically, because when the state changed its access to Medicaid and family aid to families with dependent children, that is now temporary assistance for needy families, when that was done, they divided the state into 3 sections. And those 3 sections were A, B, and C, and we are C because we are more rural. So this was done back in the 60s or early 70s. And so to create a funding system based on something that occurred 50 years ago is something that must be changed. And that's what you and I, Pat, worked on to try and fix the system, to have people listen to us. But and it wasn't just Arvind's reimbursement, it's Wyndham Hospitals. I've talked to people on the Medicare, Medicaid, Medical Assistance Oversight Council on this issue to address the fact that, you know, maybe the patient shifting wouldn't occur to the extent that it does if Wyndham Hospital was reimbursed at the same rate, say, Harvard Hospital was reimbursed at. And also, you know, if we would be able to provide more services to the incredibly medically needy area if Generations was going to get the correct reimbursement based on the population, the actual need population here, which includes a large Medicaid and Medicare population, and the same for United Services. We have a lot of behavioral health. This is a favorite place for a lot of the state agencies to place people who have behavioral health issues. We have lots of nonprofit group homes, and this is a place because the cost of the property is lower, so they want to increase that. And so what it does is it also puts a strain on the local community because there's no tax base for it. All the tax base left back in the 1980s, basically, for numerous reasons that have nothing to do with what happened in Connecticut. It had to do with how federal tax law changed.
And the dollars that we're using, or that United Social and Mental Health uses to serve its patients, they're serving approximately the same number as other areas, but they're serving it about a fifth of the cost. They're spending about $3,000 per patient per year, whereas some of the other regions are spending $15,000 and $20,000 for those same patients. And what, you know, it upsets me because it makes me feel like, that's why I said about power. It feels like the quiet corner is being consistently discriminated against for a variety of reasons. I mean, I'm sure it's not intentional, but it works out that way.
No, it's a structural discrimination.
Yeah, exactly.
Structural, you know, we have all these structural issues in our policies that have to be eradicated. And I just want to say, I want to now have Arvind, because we've been working with Arvind and having long conversations about how to try and address these things. So Arvind, tell us about all the good work you've been doing here in this region, and also how you've been working to try and make sure that we have a vision for the future. So thank you, Arvind, for, you know, running Generations and making it a good spot for people that have these medical needs.
Doing a phenomenal job.
Susan, you know, I'm standing on the shoulders of many people here. And, you know, when I first heard about these changes at the hospital, I was pretty horrified. I'm not on mute, am I?
No,
no, you're
okay. Hey, great. That's a good change. Okay. So, you know, I was pretty horrified because, you know, maternal and infant health is really one of the building blocks of healthcare. It sets up all kinds of better health options. If it's done quickly, you get folks involved in their healthcare from an early point, even, you know, in the prenatal part of it. That's where folks get involved in nutrition, get involved in, you know, lactation, you get involved in, you know, bringing the father into the loop, talking about, you know, combined approaches of discipline. And that really helps the overall family structure. So when I heard about this stuff, I was really dismayed because I felt like, you know, this is really something unprecedented. After 80 years, this hospital is pulling the plug on this service. And then, you know, just the way in which it was done without any oversight, without any intimation, people just unplugged right in the middle of everything. You know, it showed me that, you know, the hospital really is in free fall, which is a scary thing because, you know, you want things to be predictable in healthcare.
Well,
you know,
it almost seemed like they set up the conditions that they later complain about to remove services.
Well, yes, exactly, because they stopped doing vaginal birth after cesarean section.
And
this
what was
done-
the impact of, explain again to me what the impact of them stopping to do VBACs.
So, if you stop doing VBACs, what happens is that
First of all, what is a VBAC?
it's a vaginal birth after cesarean.
Thank
Okay?
you.
So it's a slightly risky, it's slightly risky. You know, sometimes babies get stuck and the mom gets tired of pushing. And if you've already had a C-section, they're reluctant to do a vaginal birth. You need to have anesthesiology waiting on site. By not having anesthesiology, because they cut that out pretty early in the game. Now, all of a sudden, 24/7, you need to have anesthesiology. But when they diluted the services at the hospital and they went from an ICU to a PCU, their census dropped and it became a self-fulfilling prophecy. Because all of a sudden, you went from 600 births to 80. And it happened at the speed of light. So, what happens when you make these changes, you've got to think of the consequences of these, because it has far-reaching consequences. Let's not talk, I will talk about the economics of it, because, for every, there's hundreds of jobs that have left the area because of this. Hundreds of jobs, at the hospital, the other supportive jobs, the nursing, the medical assistants, the CNAs, all of those. There used to be a lab over here, a full functioning pathology lab at this hospital. That's all gone. So, they capitalized on it. They sold it. They sold it to the private sector, and they made some great money with it. They've capitalized on that, and they've kept that money. But these jobs have gone from this area. What has happened now is that we're seeing a deterioration of the transportation system, because now we are having to draw much more upon this transportation system to keep moving patients. And we've had a horrible time with patients being abandoned, and then having to pick them up ourselves and transport them ourselves and calling on their behalf. And if it's a cab ride, it's okay. But what's harder if it's a patient who is in a wheelchair, or if a person is in a stretcher. I'm digressing, so please keep me focused over here, okay?
But
the issues are all interlinked.
Right,
okay?
They are.
And when you have these problems, initially they said, oh, it's a workforce issue. And I call people all the time. I talk to people. I'm always asking for help. So I called UConn and I said, do you know this is going on? And they said, we had no idea. We've got some surplus capacity. We could cover them. I went to Day Kimball and I met with the CEO over there. And I said, hey, do you know this is going on? He said, hey, look, we can handle this. It's not a big deal. So when you talk about corporate culture, Pat, this is what I'm talking about. This is how I'm relating to it, okay? Is you can't pick up the phone to call your competitor saying, hey, I need some help over here. Can you give me some assistance to get me over the hump? We are in a workforce shortage area, okay? We are in a health professional shortage area. We should not feel proud about these issues. It's just good care, in my opinion. And they should be, so, in our philosophy, we steal shamelessly and we share mindlessly. Okay? Because, sooner or later, the wheel's going to turn around and we're going to need the same thing. And so, we're always doing this as a collaboration. And even in our providers, we do that. And we celebrate that, because we think that's a great way of being able to bridge the gap for a patient, because there should be no wrong door for a patient, ever.
That's a community approach to medicine as opposed to a corporate. I don't know, maybe it's just me, but it just seems
No, you're on it.
It just seems like that.
Put your finger on it.
What we're suffering now is that it may not be shareholders as such, but it's the corporation that is almost of higher concern than the patients. I'm sure they would not characterize it that way, and perhaps I shouldn't, but it feels that way. it feels like the respect the community is getting is less than the respect that is being given to people who are managing the money or the efficiencies of the organization.
You know, healthcare is an ecosystem, and you need all the variety of an ecosystem for it to be safe and for it to be competent.
Right.
Because, you know, there are disparities in language, there are disparities in culture, there are disparities which open up now in treatment, and we've got to find ways of bridging that. And it's only through those collaborations that you really get that highest level of care, because everybody needs to be treated in a very personal way, in my opinion. If you want to move the dial on me, you know, you've got to speak to me. You've got to speak to me where I live and talk to me about the things that are important. Now, when they've gone ahead and they stopped doing the VBACs, the numbers plunged. When we went back to them and we asked them again, so what's this going on here? Now it's shifted. They say it's a safety issue.
Well, they created a safety issue.
Whose safety are we talking about?
It is a safety issue, but it's one that was created by the corporation, arguably.
But it's
And
also
whose safety?
It's safety issue with respect to the, you know, having to deliver, violating EMTALA again, when somebody's in active labor, no matter where they are in the active labor, they're still not stabilized if they're in active labor. So they should be taken right where they go, and that should be right at the emergency room, at least at Wyndham Hospital, but they should not be sent off. And this is exactly what EMTALA was designed to stop, is to stop people from having babies on outside of the doorstep of the hospital, for example. A lot of times they were doing that because they were neither covered by Medicare, Medicaid, or private insurance. So EMTALA was that way to equalize access to healthcare. So now we have doctors that are not feeling safe here because of the lack of the critical care unit and having that staffed, and doctors, according to Hartford Health, who are not providing services because they can't get anybody, which is, you know, which Arvind said he could help, you know, facilitate that. And we're having people who are really now put at risk for, you know, any type of delivery because of that. In fact, what it does is it kind of sets up what used to be what, you know, my family comes from a very rural background. And back in the day, what they would do is they would go the last 2 or 3 months to where the hospital was and deliver that way. So what are we setting it up for? This is definitely setting up rural style healthcare delivery. Are they going to set up rooms for people to be able to live, say, at Bacchus or in Manchester or in Hartford, so that they can deliver safely? I mean, that's the kind of, when I think of this, I think of, yeah, maybe that's what they should be doing if that's the way they're going to do this. But I don't.
And remember, that was one of Mrs. Gonzalez's concerns, or Miss Gonzalez's concerns, was the incidental expenses related to deliver, you know, having to deliver that you're talking about in a community not your own.
Right.
Well, you can't just pass the risk on to patients. That's just not, you know, this is absurd, because you're going to get the worst of both worlds. You're going to get poor care and you're going to get bad outcomes. We can't afford this, not in the 21st century. So, you know, my sense is there are a couple of things that need to happen over here. Okay. The first thing, the primary thing that needs to happen is that the regulation has to be fixed. The regulators have to be able to regulate. They need to be able to do this in a quick way. You know, when people change their course of action and say they're not going to do VBACs anymore, it needs to be heard. It needs to be heard by the public. Somebody needs to say something about this. The second thing that needs to happen is that if a provider gets into hardship and gets into trouble, and we do all the time, it's just a matter of time. It's just a matter of time before I'm going to be running around like a chicken without my head asking for psychiatry. Okay. And you know, because there's a very big shortage of this in our community.
All of these things,
and that's why United Services, you know, they're endangered. They're endangered in a very, very primary way. So the second thing is there's got to be an agreement that folks can collaborate with cooperation and collaborate at the highest possible level, so that they allow, you know, the other providers to come in here with the same privileges.
Exactly.
You know, the way hospitals are organized today, You don't get privileges at the hospital if you are not really, of the ilk, the same ilk. So these are the issues. I mean,
I'm going to cut in if I
the choice
could.
that I would like to have. Hang on one second, okay? What I would like to have, I would like to see a much more permanent and systemic change in this hospital, something which would allow this hospital to actually be involved in what's called a rural healthcare delivery system, which would include a residency.
Right.
If you can use this hospital, and this is my pitch. My pitch to the hospital has been, look, let's get it together. We've got a couple of universities over here that would really, lend themselves to a low volume, high quality delivery system. And we use those funds, those academic GME dollars, the graduate management education dollars, to provide these services in a comprehensive way, so that, I think women in their childbearing years should be given all the support they need.
Yes.
Absolutely. And there's no question in my mind about it, because I think it's a hallmark of our civilization. We will not be able to succeed.
The foundation
okay,
for the rest of life.
I'm going to stop. And we have a question over here.
Lisa Thomas is next question. Yes.
I have a comment and a question.
Sure.
My comment is, in listening to you talk about the VBAC situation, and Arvind, I haven't heard that come up in the other meetings that I've attended with you all, but I know that 22 years ago, my OBGYN practice supported me in making that choice. So I am wondering if part of that refusal by hospitals, or maybe just Windham Hospital, to offer VBAC is more of a legal issue and a fear of lawsuit issue than they're claiming to be more of a safety issue. I know my doctors provided me all the information I needed in order to make the choice, and they supported my choice. The other thing I wanted to mention, I know that we need support in terms of letters to Hartford Healthcare and some pressure from surrounding communities. And Steve Jones is on this call, and so am I. So Steve Jones is Tolland and I'm Coventry. And I would like to see us bringing this issue to our council tables. And I know Mansfield just passed, unanimously decided to send a letter to Hartford Healthcare protesting what's going on. And so unlike Mansfield, Tolland and Coventry are not controlled by Democrats. So I'm curious to know if there's time, or Tony, maybe I can talk to you separately, how you managed to, how you presented that in order to get a unanimous vote to send that letter.
And let me just add at this point in time that not just to Hartford Health, but to the Office of Healthcare Strategy, because they are the regulatory agency that reviews this. So all the good letters must go to the Office of Healthcare Strategy at this point.
Right. I was going to say Hartford Healthcare, you can copy them.
Yeah. Vicki Beltry is who runs the agency. Also, former Senator Terry Giarratana is working there. She's the one that helped us when I chaired public health with her. We worked on creating the Office of Healthcare Strategy together. I've gone to national conferences through the Milbank Foundation to discuss the work that we've done, because it is innovative and it is to try and make sure that we have an equalization of access to healthcare. And if you go back to your old law school classes about medical malpractice, well, you don't get to have the same kind of result in a rural area if you file a claim, because they don't have the access to resources. And so my guess is this is somehow the insurance industry is a player in this that has not been able to we haven't been able to fully understand at this point exactly how it's working with their premiums for the doctors and for Hartford Health. So I think that those are some of the considerations that we should take a look at. But please proceed. And Tony, if you could answer Lisa's question, that would be great.
Tony.
You're muted. Get unmute.
Yeah, I've had stuff going on around me, so I was muted. First of all, the Mansfield Council wants to be as supportive of Windham as possible. And although there are rural poor in Mansfield who use that hospital as well, I think there was a real sense that we wanted to support the community in Wyndham. But aside from that, personally, my son was born literally 49 years ago. 49 years ago, the obstetricians and gynecologists in this town were recommending that women go to Manchester. When I went to Wyndham, most of my friends said, "Why are you going to Wyndham? It's not as good as Manchester or even Bacchus." And I think the bleeding away of pregnant women from this hospital has been going on a lot longer than it's been taken over by Hartford Hospital. Plus, we know that there's a real decline in birth rates. So, I mean, aside from these medical emergencies, there seems to be a real decline in a number of normal, healthy pregnancies. And I think those are necessary to sustain a birthing center at a hospital. So I'm wondering, how do you deal with the fact that there aren't enough regular pregnancies coming to that hospital to provide the experience and the training for the staff necessary to keep it open?
Arvind has all
Yes,
the
please.
answers on that and the data.
So, so I looked at the literature. Okay, there is a lot of literature that is produced about maternal and infant health. CMS and the CMS, the Office of Medicare and Medicaid, have commissioned many of these studies because maternal health has been a very serious issue.
Yes.
Okay. Also, I looked at the College of Obstetricians, and they have published literature, and nowhere in the literature is there anything which says what is the minimum, okay, of a delivery for successful delivery, whether it be rural or whether it be urban. So there's nothing in the literature which is actually evident, which says that this makes it unsafe or this doesn't make it unsafe. Now, so let's talk about the economics, okay? So if we've taken the science out of it, and the College of Obstetricians have said, look, there is no minimum that's necessary. So what is left? It's the economics. Now, in economics, they make a ton of money on imaging. They're investing $1.5 billion in Fairfield County. This is Hartford Healthcare. Okay, $1.5 billion, okay, which is many, many zeros, all that's needed to fix this hospital is really 15 million.
A couple extra zeros.
That's just a few zeros, okay, in my opinion, okay? And, so it's not really a question of, and it's really a question of priority. And like in life, there are things that you're going to lose money on, Tony, but there are things that you're going to make money on, okay? And you shouldn't count the change in your pocket. This is like change in your pocket. And in my opinion, it's in the change, there's a change in the pockets of the poorest patients that is being picked right now, which is absolutely not allowable.
That's the devaluation. That's
it's commoditized.
That's the lack of power.
Why is this being commoditized like this? Public health is difficult. I grant you that, okay? It's not meant for everybody. But the reason why we trust the hospitals to do public health is because they have a community benefit that they've provided here for 80 years, okay? They are given tax exemption, okay? Now, all of a sudden, say we can't afford it, and we can't afford it for these minority patients is kind of very contrived, in my opinion. And I think you need to have a very much higher level of justification in something like this.
Thank you.
Folks, I hate to jump in and be the bearer of bad news, but our time has come to an end. We want to give you time to get into their next section, to refresh their coffee or take a quick break. I sincerely want to thank all of you for giving up yet another Saturday morning for politics, and especially to Arvind, Susan, and Pat, my three go-tos on anything in the quiet corner, not just healthcare. You three of you do amazing work. And my plug for Generations, that's where I go for all my primary care, and they are as good or better than any other care that I've ever seen. So it's community health is not just if you're on assistance. Anyways, thank you again, everybody, and we'll see you at the next section.
Thank you.
Be
Thank
right.
you.
Thank you.
Thank
Very
you.
informative. Thanks.
Thank you, guys.
Thank you.
Bye-bye.
Thank you so much.
Bye.